All right, hello, I'm Adam Jennings, Special Forces medic, I used to be, and did that for about 7 years, and then decided I needed to get up here to New Hampshire and be part of the Free State Project. So I'm going to give a talk about austere medicine, how to save everybody's life in a survival situation, far removed from medical care. What are the first couple things you can do? I'm not going to try to get too deep in the woods because it's an hour-long class, and I'm going to do a question and answer session at the end, but really it's just what are the few things that if I can do could save my friend's life. And so how many people out here are paramedics, CPR, was in the military, did some type of CLS training? So how many people have heard of the ABCs? So airway, breathing, circulation, how to step through, make yourself your own algorithm for care? I don't know. All right. I'm not good with microphones. But anyway, so a couple years ago, Special Operations Forces, so the SEALs, Army SF, and Rangers, and then the Air Force PJs, they all got together and said, hey, something's wrong with this ABCs. We're losing a lot of guys because of things that happened before the airway. And so they came out with a new algorithm, and they call it the March algorithm. So I'm basically going to step through that today. I'm going to talk about what each of the words mean, or the letters mean, and then go from there. So the March algorithm stands for massive hemorrhage, airway, respiration, circulations, and then hypothermia. And I'll touch on the last one right now. Hypothermia, the old standard was to expose your patient. A couple of you that have prior medical experience on this, expose your patient, look for all injuries. People were forgetting to cover them back up. And then once they're cold and injured, now they're in shock. Now you have a harder time bringing them back. So they added the hypothermia at the end so that when you're done doing the other things that could save your buddy's life, make sure to cover them back up. Space blankets. There's all different kinds of things to use that. So anyway, so massive hemorrhage. Civilian EMS, they don't really talk about tourniquets. But if you're far removed from a hospital, you have to know how to use a tourniquet. Because civilian EMS, they're close to a hospital where they can get those packed red blood cells, where they can get the whole blood. They have access to get more red blood cells, the oxygen carrying capability back into your blood. When you're out hiking, survival situation, whatever it is, and you're not, you have to stop those red blood cells from leaving the bloodstream. And so the way you do that is with a tourniquet. So this one's basically like a ratchet strap. They just put a little cover on it to protect your buddy's skin. And so all these, if you look at all these, they have a way of getting tighter than just wrapping it around the injured limb. And a couple things that if you're making a homemade one you want to think about is 2 fingers width. This one's a little skimpy, but you'll get a longer reach on the blood vessel. And so you'll be able to clamp it down easier. The wider you have to put less pressure, the wider the tourniquet is. There's a physics equation for that. But anyway, so this one, the Army Rangers were carrying this for a while. They call it the Ranger Ratchet. They just took a ratchet strap and stuck this little pad on the back of it to protect it from digging into the skin when you start ratcheting it in. Some other special operations decided to come with, they took the old windlass style. This is a homemade one I'll talk about in a second. But they call this one the soft T, and it has a little thumb screw here that you can undo, and you get as tight as you can, and then you use this to finish the last couple bits of the tightening. These were pretty popular for a while, but there's another one I'm going to get out in a second that's kind of replaced that. I made this one for about $2. I found these are like hangers for picture frames at Home Depot, and took a dowel rod, cut it up, and put a second one on here to provide the safety or the latch once you put it on. So you can wrap it around and twist it, and that's the name behind the windlass. And then once you get it as tight as you need it to stop the blood flow, you can just stick it in the other ring. the same kind of thing that I made. I just took a piece of 550 cord, paracord, and I had another on there, but that's why this isn't very good. You need something that's maintains its shape and when you're not using it, so that other piece doesn't slide off. I've seen people use Gatorade rings, like a Gatorade bottle, to do that, and then just use electrical tape. Piece of cloth. These are military-style cravats, but any cloth will work. Something that's not going to break under stress. Now, if you want to go out and spend money on a tourniquet instead of using the $2 version, this is the prepackaged CAT tourniquet, Combat Application Tourniquet. It basically took the same model as that and then just made it into a nice little Velcro band. Same thing, tighten it down and then use the windlass. It's got a nice little safety on there that you can stick the tab in and then cover it up. So now that I passed around tourniquets, we'll get them around there. Some things to remember with them: they're only used on extremities. You want to keep them away from the joint, a hand's width away from the joints. You're going to be able to get better blood vessel access that way. You get close to the joint, now they're buried in the blood or in the bone sometimes. You can use it on the forearm and the lower leg, but realize you have two bones there and the blood vessels run between them, and so you're going to have to really cramp down. So if you need to, just put it on one of either the humerus or the femur, because this one bone, you can push the vessels up against the bone, and now you've got occlusion. So when you think about stopping the blood flow, you might not stop all of it, but you want to stop the bright red, high velocity blood flow. So if it's squirting out, it's pumping out. They're going to be injured, so their heart rate's going to be elevated, so now it's going to be pumping even faster. So just stop that bright red blood flow, and then just continue to reassess. Anytime you move your patient, you want to make sure that the tourniquet stayed in place. What else about tourniquets? Yes? Okay, good question. What kind of damage do you have to the limb? In the hospitals, they leave them on for up to 8 hours at a time. I've seen them used for about the same length of time, take it off. Just a little bit of damage on the tissue where the tourniquet was, but no permanent damage to the limb. So don't be afraid to use a tourniquet. That was the old, once you put it on, now the limb's ruined for life. No, use it, save everybody's life, and then get them to somebody more advanced. There's ways to reduce the tourniquet, but that's a little out of scope of what I want to talk about today. Basically, putting pressure dressings right on the vessels, and then wait a couple hours and loosen the tourniquet, and then you go from there and just keep reassessing. So there's a lot of reassessment when you have an injured, when you have a patient. So after the massive hemorrhage, because you can't get red blood cells in the field, then you need to worry about airway. You have about 3 minutes to live without air, and so you start looking at things you can do to the airway. The biggest thing is just put them in the recovery position if they're unconscious or if they're loopy because they have a head injury or something. You can manually clear their mouth. Be careful of being bit. And then respiration. So then you want to take a look at the chest and see if there's any chest trauma. And so there's a whole bunch of devices out there that have been created to make quick application of chest wounds. Nope, I did not. So the recovery position is laying them on either the left side or the right side. There's different schools of thought why you want to lay them on the left or the right, but basically knee bent, laid on their side so they can't roll completely onto their face, but enough that if they have something in their mouth or they need to vomit, that they have it can go out without coming back into their airway. Any other questions?
If you do have questions, I'll bring you a mic, or you can come stand.
I'll repeat the questions if.
It's not preferred.
It's not preferred?
Sometimes words get changed a little bit, I guess. That's what I was asking.
Okay.
Related
All right.
to
All right. So, in the old military manuals, they took a MRE bag and they stuck it to a chest wound, and somebody decided that wasn't enough. So then, what I learned when I went through was take a piece of petroleum gauze and put a layer of tape around it and stick that on. So a Navy SEAL came out with named Asherman, came out with the Asherman chest seal. Same kind of thing, rips off and it just sticks right on. it's a little bit smaller than what I had made or what you can do with an MRE bag. But for a small penetrating trauma to the chest, this will work. So that was like the first generation of the pre-made chest trauma kits. And after that, a couple other companies came out with the Bolin and the Hyphen. The Asherman has a one-way valve on it so that if there's built-up pressure, it'll come out. The Bolin has the same thing on this one. The Hyphen is just a flat sheet of sticky material. Asherman doesn't stick quite as well, so if you encounter some of those, be prepared to use tape to reinforce it. These both have a better adhesive on them. While I'm talking about the valve, there's different schools of thought on why you'd want to use the valve. The old military manuals, if you see any of those, any of the old first aid manuals you find around, they talk about leaving one side open to release. Well, then you have a chance of letting more air into the space. So I'll get into a little anatomy now. So when you have penetrating chest trauma, it usually doesn't affect the lung. It usually just affects the chest wall. So now you have the chest wall, and then the lung is inside a sac, which is inside the chest. And so air is coming, when you breathe in, the least resistance is through that hole in your chest. And so that it expands outside the lung, and now your lung starts to deflate. Or doesn't have as much room to expand because this air is taking up the space where the lung should be. And so to combat that, you put something on one of those seals on there, big piece of duct tape, a chip bag, anything you have to put on there and prevent more air from entering the lung space but not actually in the lung. And then there's advanced things you can do to reinflate the lung after you have one of those on. But really, if you get that on soon enough, you don't have to worry about doing those other things. So if you're with your friend when that happens, you know that's good enough. And then after respiration, you get down to circulation, your Markov algorithm. So massive hemorrhage, airway, respiration is down here in circulation. Now you start looking at all the other smaller injuries that weren't massive hemorrhage, that didn't require a tourniquet. Was it a place that you couldn't put a tourniquet? Axilla, the groin area where you can't put a tourniquet. Things like that, you want to use some type of pressure dressing. So ACE wraps and wadded up shirts work just fine. And then they come up with these dressings that combine that packing material and the ACE wrap. And so this is called, I don't know what the actual name, we call it the Israeli dressing because somebody in Israel developed it. But it basically combines the cloth, the cotton cloth that you want to put on directly on the wound with the ACE wrap so you can get the pressure on there. Old EMS protocols talked about elevating the extremity, putting direct pressure on there first. I recommend going directly to some type of pressure dressing, skip the elevation and the direct pressure, put that on there. I mean, you can use direct pressure while you're applying that, but get that on as quick as possible, something like that, or an ACE wrap. Or an ACE wrap. And so here's a larger version of some of the space blankets. They've got a lot smaller ones now, ones that'll fit in your pocket. Actually, I have a couple at my campsite. But anyway, remembering that hypothermia thing, your patient is now has some type of compromise, either chest, some type of trauma, and so you need to prevent him from going into shock. And so space blankets. Laying next to your buddy, or if you're moving, just wrap around their shoulders, and if they can still move. These don't make the greatest litters. They will rip, but if you need to, and you can double it up and try to, carry short distances on one of these. The smaller ones, you're definitely not going to be able to put somebody on. But that's why these are decent, because even though they're a little bit bigger, you can carry somebody a short distance on one of these space blankets. So massive hemorrhage, airway, respiration, circulation, and hypothermia. I know that I'm way short on, I went way quick on that. But like I said, I don't want to get too deep in the weeds, but if anybody has questions, I'll take some questions relating to that kind of stuff. I don't want to go over every medical thing known to man. But I want to give you a couple of references real quick. There's a website called primary-surgery.org, and it's a nonprofit out of Germany that does a lot of work down in Africa, and they have a whole bunch of, well, it's split up into two manuals, one that's trauma and one that's non-trauma, and a whole bunch of free PDFs you can get online. Primary-surgery.org. PRIMARY dash, yep, surgery. And then this is what I think is the gold standard, is the Special Operations Forces Handbook. This is what I was issued when I went through training. They're on the next version now, but I like to keep mine. You can get it on the Government Printing Office GPO website. Just look for Special Operations Forces Medical Handbook. I worked with the chief of the University of North Carolina Burn Center a couple years ago, and I brought this to him, and he was like, wow, you cover more in this one book than I cover, and he showed me his whole one wall in his office was covered with books. He said, you guys cover more in here. It goes from trauma to survival situations to appendectomies to OBGYN, veterinary, dentistry, a little bit of everything, and there's even diagrams to show you where to cut to do an appendectomy. So I wouldn't necessarily try it if you didn't have any medical experience, but hopefully somebody in your crew does have some type of medical experience, and they can say, wait a minute, I know this part of the anatomy, and this will be that one thing that'll save your buddy's life. Yes, there are things in there that are, just know your limits. That's the best thing to know about doing any type of medicine, is know your limits. Know when, hey, I'm out of my water. I can do what I can do what I've showed you today, and then I've got to get this person to do some type of higher level of care. I'll take questions now if anybody wants to come up here. Okay.
Hi, Adam. I have a question for you. As an avid hiker and also as a trail volunteer, I've occasionally come across people when hiking that have needed some first aid attention. Now, fortunately, the cases that I have personally encountered have been minor: dehydration, sprained ankle, that sort of thing. I noticed on your chest trauma packages there is some restricted labeling. Is that something that me as a lay first responder can access? Or
yes, you can buy those. I think Amazon sells all that stuff. Okay. So that's where I go to get most of my stuff, is Amazon. But be careful about the law. Be careful about the law. The point is, for this, save your friend's life. I have no other options. I would risk a lawsuit from my buddy, kind of thing. I wouldn't necessarily say go out and do this to strangers, but if you're with your friends hiking, that's when I would say apply what I've showed you today.
Fair enough.
Question in the back.
So there's this, I'm sure you're familiar with this, like powder that you could pour into a severe laceration. Do you have any experience with that?
Yes, I do. So this is Quick Clot. I think you actually buy this too on Amazon. And so the blue label is the second generation. The first generation had a black label. It got really hot and would burn both the patient and the first responder that was applying it. Things with these is they have to be in direct contact with the vessel. If you're not in direct contact with the vessel, it's not going to start the cascade response, and you're not going to get the clotting. So basically, these are nice to have, but not a need to have. If you can directly access the vessel with this, you can directly access it with a piece of cloth. And once you get that pressure, that's going to stop the bleed anyway. So I think these are way overhyped. Don't go out and spend thousands of dollars on these things. If you can come across them at a cheap price, yeah, throw it in your kit. But direct pressure right on the vessel is what you're going to have with this. I actually worked with a doc in Balad, Iraq, and he couldn't get a GI bleed to stop. He had a guy's belly open, and we cut it open, and he put it right on there. And so it did stop it, but just because he couldn't clamp, he wasn't able to put direct pressure. But you're not going to be opening somebody's stomach to do that. So if it's on an extremity or axillary, if you can get direct pressure onto the vessel, this is a nice to have, not a need to have.
Thanks. What kind of airways do you have in there, and do you have any thing to say about different airways?
Okay. Be careful with intubations and endotracheal tubes. Using a laryngoscope, if you're not trained on it, people fail all the time. And they think they're actually in the esophagus, and you're pumping air into the stomach, and now you're going to increase more problems with vomiting. There's a couple different versions that the military has tried out. One was called the combi tube. You just shoved in there blind, and you tested to see which one was in the lung. Wouldn't recommend that. The Ranger started carrying a thing called the King LT. You shove it in enough that when you inflate both bulbs, if you're in the trachea, it's going to inflate the lungs. If you're not, between the bulbs, the one bulb will be in the esophagus and one will be up in the upper larynx, and you can actually pressure bag that way. They're just really complicated to use without training. If you have them,
How about some of the more simple ones like nasopharyngeal?
okay.
In the microphone?
How about the more simpler ones like nasopharyngeal, oropharyngeal?
Okay. I actually have a couple of the OPAs that he was talking about, different sized. Problem with this is your patient will probably be completely unconscious and unresponsive. Otherwise, you put this down, it's going to mess with the gag reflex. So what I would use an MPA. So these are nasopharyngeal airways. So you stick these down the nose, and then it goes down. The idea is it goes past the tongue, and it holds the tongue in front of it so that you can let air down. But if you put them in the recovery position, their tongue's gravity's going to hold them down anyway. So another nice to have, but not necessary, I guess. In worst situation, you could take a safety pin and clip their tongue to their lip if you have to transport them on their back. But if they're that far gone, you got to be doing everything you can to get them out of there to do higher levels of care. Yeah. Any other questions? If you want to come up and check my aid bags, ask me questions offline. I'll be around all week. So. Oh yeah, I'm doing a class on Friday where you build your own aid bag. It's $25, and I have all the gear for it. And we're gonna build our own tourniquets. Gonna build our own chest seals. Then talk about a couple of things you want to have in your aid bags.
Can I sign up right now?
Yep.
Can I sign up right now?
Yeah. If no other questions, feel free to come on up. Oh.
Yeah, can you say something about, well, you just mentioned aid bags. If we take your class, is there an aid bag that would suit any situation, every situation, or are there different?
Nope, and that's the problem with austere medicine. You know, when only medicine you have is on your back or in your car or whatever. I mean, you have to plan for the most likely scenarios and then have a couple nice to haves afterwards. So, like, for instance, like I carry ET tubes so I can intubate somebody, but I can also use the same tubes to do it to do chest trauma, so I can fix chest trauma that way. So try to use things that have multiple uses, I guess. Does that answer your question?
You have a thought that I'm going to take things with me in any particular situation that are inappropriate or I don't need. So I just want to be clear in my head, what do I have here that I can really would be useful if I'm going for here on a weekend hike, or if I'm, going in the water or whatever. So I just wonder if you could make some distinctions about what are the fundamentals that apply everywhere, maybe, and then.
Okay.
Yeah.
I recommend having 2 tourniquets. One is a backup in case the first one breaks. 2 chest seals, 1 front and back. So if you have a through-and-through gunshot wound, get stabbed with a piece of rebar all the way through the chest, kind of thing. And then ace wraps and some type of cloth, because ace wraps can do for the sprains and the strains, and then it can also be used to provide those pressure dressings. Don't forget Band-Aids. I know a lot of medics in the Army would always forget Band-Aids because it's something little, but that's where you're going to see most of your things is, cuts and scrapes. Any other questions? Yeah.
So one thing that I learned to add on to that, if you're building your own trauma kit, like for me, I have one that I build for hiking. One thing you can consider is put it in a waterproof plastic bag and keep it on the outside of your pack. The thought process is, if you're with somebody and they're seriously injured, seconds matter,
Right.
and you don't want to spend time digging in your pack.
Right.
So your emergency supplies are right there at hand.
Right.
Hopefully I'll never have to use it, but
Yeah, when I was deployed over the Middle East, we would carry tourniquets on our body armor in the front. You can access them with either hand, and then also in one of your sleeve pockets, the same kind of things that I just, a little kit in a food saver bag, compressed in our shoulder pockets.
Yeah, I just had a question about like compartmentalization and toxic shock and that kind of thing.
And what?
Toxic shock and compartmentalization, like when does that come into this
Um,
type of thing?
Shock is going to be losing you're actually kind of in shock when you give blood. So if you think how little they take when you give blood, you're in the first stages of shock then. So it doesn't take much. The best thing to do is prevent them from going further down the rabbit hole. So get those tourniquets on quick, stop the blood loss, stop the hyperventilation, stop the collapsed lungs, keep them in homeostasis as much as possible.
How about compartmentalization where?
Compartment syndrome?
Yeah, there you go.
So usually that's going to happen. It takes a lot of blood because you can lose up to 2 liters in your upper leg before it even starts showing on the outside, or before you see any outward symptoms. So for that, I mean, there's actually in that book they talk about doing fasciotomies and escharotomies to cut through and relieve the pressure. But again, that's way over the scope of what I want to talk about today. Is that it? Feel free to come up and check out the aid bags. Make sure you check out that book, GPO's website, Special Operations Forces Medical Handbook. That is, if you're going to get one book, I think it's $50 on there. It is the go-to book.
humans, as fragile as the dawn.